Cast is now starting. All attendees are in listen-only mode.
Hello, everyone. Welcome to this training on ending nursing home violence between residents, prevention, intervention, and advocacy. My name is Carol Scott, and I'm the Ombudsman Specialist for the National Ombudsman Resource Center, or NORC. Thank you for joining us today. In the toolbox on the right-hand side of your screen, you will see that there are a couple of handouts that you may download at any point. We will also be sending them out with a recording of this webinar following today's presentation. So if you want to share those with other colleagues, you are welcome to do that. The handouts are the PowerPoint that's being used today, and also a advocacy guide for ombudsman. If you have questions of the speakers, or if you have technical questions, you may write those in the question box to the in the toolbox. Just look for the questions and type it in there, and we'll either respond immediately or we will hold your question till the end of the presentation and get to as many of those questions as we can. I am pleased today to have Dr. Carl Pillemer, Professor of Human Development with Cornell University, as one of our speakers. Many of you received a copy of the presentation that he did for us 2 years ago in 2016, and I hope that you had a chance to listen to that webinar, and if not, we will be sending a link to that when we send a link to this one. Also joining us is Sarah Sosa Gussler. She is a long-term care ombudsman representative from Michigan, and she'll be talking about a presentation that they're doing in their part of Michigan on bullying, and share with you some of the things that they are finding out as they do this training. So at this point, I think, let me think just for a second, I think I've done all the housekeeping. Be sure and write in questions. Download the handouts if you want them now, or again, we'll be sending out the link to those handouts also later. So at this point, I just want to turn it over to Dr. Pillemer. Thank you for being with us today.
Oh, well, thanks so much. And I'm bad at technology, so I'm assuming everyone can now hear me, and I'm now officially the speaker and presenter. If not, Carol, let me know. I am really, really pleased to be here today. I, have been involved with this organization on and off for a long time. And for those of you who don't know me, I will say a word. I'm both at Cornell University, but I also am a faculty member in our division of geriatrics at the Weill Cornell Medical College. And really for my whole career, which now is getting very long, I've involved in issues of understanding elder abuse, elder mistreatment, in a variety of contexts, and in particular also in long-term care. And I realized it was 1985 when we did our first study, or right around then, of the abuse or mistreatment of older people in long-term care facilities. And ever since then, I've had an interest in that topic. I'm mostly a researcher, although almost all my career has been spent with organizations like this and with folks in the community, because the research I do is community-based and done in partnership with organizations and groups. And that's why I'm really thrilled to have another opportunity to talk to this group, and especially to so many of you, because I see we're over 220 of you. I also want to say that we may not get to everything. If you Google my name, you'll come to my Cornell University webpage, which will have my email address, and you're welcome to email me as well. I want to add one other bit of introduction in the interest of full disclosure. When Carol asked me if I would come on again, I said yes, but I'd like to maybe do something a little bit different. And very often when we give presentations like this, we are talking about a project or a program that's completed and we can be really definitive. And I said to Carol that my colleagues and I at Cornell and some nationally and even internationally are thinking about this idea of developing a campaign or a program specifically around the issue of violence in nursing homes. And I will say, I kind of gave the wrong title. It's really not ending nursing home violence between residents. You'll see that my talk is more global. It's, can we talk about ending violence in nursing homes? I think Sarah's going to talk more specifically about problems between residents, and I'm going to touch on that. But my question for you and for everyone on the webinar to think about, and maybe you can get back to me, is can we begin to think about violence prevention in nursing homes as a specific problem, as an independent problem to a certain extent, and one that might be compelling to try to remedy? So the reason why I say this is a little bit of a work in progress, and I'm coming to the field, you folks out there, to see what you think of this approach. So the question is, or my colleagues and I believe, that one thing, and I'm not sure, let's go to my next slide. And I'm a little technologically challenged, so bear with me. But one thing that we can do to improve the lives of vulnerable older people is to create a national call to action to end nursing home violence. So we've talked around this problem for decades. You know, in my case, I know people have been talking about it for 30 years or more. And it's our feeling that we need to take it on now directly. So as all of you know, quality of care in nursing homes has been a major topic for research and regulation and policy debate for at least a half century. And despite persistent issues with quality of care in some facilities, in general, the public acknowledges both the need for long-term care institutions, and the public assumes that accepting financial constraints and so forth, nursing homes in the main are providing competent and compassionate care. And that's what surveys show us. That if you survey family members, for example, or the general public, you know, there's a sense that a lot of nursing homes are doing as best they can. And in the main, this view is correct. But over the years, there have been persistent calls for improvement, ranging from incremental changes in regulations to sweeping efforts to entirely change nursing home culture and to create completely alternative care concepts. And I'm sure that some of you have been involved in those efforts. One enormous problem in nursing home care, though, is, I would say in quotes, hiding in plain sight. And this is the fact that nursing homes, where care is provided to the most vulnerable adults in our society, also have some of the highest rates of violence and aggression and conflict of any social institution. So it's this contrast between care on the one hand, care and vulnerability on the one hand, and conflict and violence on the other, that really creates a unique and jarring paradox in nursing home care. It's really very striking that we have these two very different things. Now, the public is occasionally made aware of nursing home violence in cases so tragic or disturbing that they make headlines. So this, I think, was in the UK, but it was examples like this, where a staff member brutally assaulted an 81-year-old woman in his care. And that's, so this is a headline. And some of you may have heard of this, violence between residents sometimes becomes very highly publicized. Like, this is a case of a 98-year-old nursing home resident who was one of the oldest people ever indicted on murder charges because she strangled and suffocated her 100-year-old roommate. So people become aware of violence in nursing homes through extreme cases. And these kinds of news items typically raise short-term calls for action, and then they disappear into the next news cycle. However, at the risk of using a cliche, they really are the tip of the iceberg. As I'll demonstrate now, violence and the precursors to violence, like interpersonal conflict and verbal aggression, exist at a level in nursing homes that would be considered epidemic if it occurred in other settings, like my workplace and most people's workplaces. Indeed, it's probably not an exaggeration to say that the only institutions that have interpersonal aggression and violence so embedded in the daily routine of living are mental hospitals, prisons, and residential facilities for troubled adolescents. And so how much violence is there? So why do I say violence is endemic to nursing homes? And let me say a qualification. As a researcher, I'm usually a stickler for very precise definitions. And so when we research violence or physical elder abuse, we usually define violence as acts carried out with the intention of causing physical pain, harm, or injury to another person. But of course, we have to take a broader view when we're talking about nursing homes, because we often have demented residents for whom intention isn't really clear. And there are also other actions that are aggressive and often lead to physical violence. So I'm going to include, to some extent, a discussion of verbally aggressive behaviors. So let's start with the assumption for the moment that zero violence ought to be the norm. So in my university job, I've never, over 30-odd years, had any kind of a violent incident. I don't think I know any other faculty person who's been involved in a violent incident. And if I had someone even yell at me angrily, like a student or a colleague, it would be so unusual that it would be a really big deal. And that's the way that most environments are. So we don't expect violence to occur. If then, how much violence is there in nursing homes? From the assumption that zero violence ought to be the norm, the answer is an enormous amount of violence goes on in nursing homes. And there are three kinds in particular. There's staff-to-resident violence, there is resident-to-resident violence, and there's resident-to-staff violence. And let me say that I'm going to give you some statistics, but I want to, as a good social scientist, there are some limitations of any estimates. There are very few studies, and some of the studies are old, and findings about the prevalence, that is, the extent of violence, certainly underestimate the size of the problem, because staff and residents and their families may not admit it because of social desirability. It's very hard to observe it, because if someone's observing, violence may not take place. And we have learned that there's very limited record keeping of incidents of violence. And I'll tell you why that is. It's more later, but in part it's because they occur so frequently that staff don't view them as unusual. So in terms of staff to resident violence, and you'll see at the bottom of this slide how old this study is, but we did, the only real prevalent study of staff to resident violence over 25 years ago. There have been some smaller studies which seem to indicate that these statistics are correct, but if you survey staff, around 36% said they had witnessed an act of physical violence by staff over the past year, pushing, grabbing, shoving, and so forth. And 81% had witnessed verbal aggression by staff. 10% reported that they themselves had responded in a physical way that they later regretted. And 40% reported that they had engaged in verbal aggression. Now, we don't have new statistics, but there's no reason to believe that these have particularly changed. I won't say too much about resident-to-resident violence and mistreatment, because I did give a full webinar on that. But I do, to make this point of how extensive violence is, I do want to touch on it. And in the big study that we did, it was in 10 skilled nursing facilities. We assessed 2,011 residents using a wide variety of methods: staff interviews, resident interviews, observations, records reviews, and official and the facility's data, like incident and accident reports. And what we found was that in just a month, over the past month, about 20% of residents had been involved in some kind of resident-to-resident elder mistreatment incident. And in terms of the kind, in terms of physical resident-to-resident altercation. So a resident had been involved in a violent altercation with another resident. It was close to 6%. Now, this isn't really totally accurate, but one way of looking at that is if you think of the total U.S. nursing home population, it would mean around 74,000 U.S. nursing residents experience a violent altercation with another resident each month. In terms of verbal aggression between residents, it was around 16% in the past month. Unwelcome sexual advances or harassment was around 1.3%, and there were a variety of other kinds, like aggressive wandering into someone's room or different kinds of threats were around 10%. So that is a lot of resident-to-resident altercations, and since we assumed that we missed a lot of it, having 1 in 5 residents engaged in something like that in the course of a month seems very high. As part of this same study, we also asked staff about residents being violent towards them. And in just a 2-week period, close to 8% of residents were reported as being physically aggressive towards staff. Around 12% were verbally aggressive. So between 15 and 16% of residents were identified as being aggressive towards staff in just a 2-week period. So I'll come back to what I said earlier. If we think about the problem of violence in nursing homes, so these institutions where the most vulnerable people are cared for, and you compare them to almost any other institution, be it a school or a child care center or whatever, there's a lot of violence and aggression, way more than appears typically. And the reason why this is so important is that research suggests that it leads to morbidity and mortality, so that there have been studies showing that violence among residents and towards them can involve fractures and dislocations and bruises, and the frailty of residents makes these kinds of altercations potentially very harmful. Simply, obviously, experiencing violence has negative psychological consequences for residents, but because this is a very closed environment and you can't get out, observing a resident victimize another resident affects their psychological well-being. And there's evidence from community elder abuse that if you're an elder abuse victim, you have a greater chance of dying. And we assume that that's the case in nursing homes. And finally, there are obvious negative effects on staff. Staff are the most likely to say that it's immensely difficult for them to deal with resident-to-resident aggression, and resident aggression towards them is one of the most stressful aspects of their job. So if you'll agree with me that we have a situation where that if you were, like every once in a while, people pretend that a Martian has come to look at something on Earth, or that an anthropologist from 100 years from now comes back through time and looks at how we are, they would find this, I think, extraordinarily unusual and difficult and problematic. But I have found my colleagues and I in our work, that 3 things stand in the way of reducing or eliminating nursing home violence. And those are acceptance and ignorance and inaction. And let me start with acceptance. When I have given many presentations on this in this country and all over the world, and I very often get the question, yeah, sure, we know, but what can you really do about it? What can you do? And I've learned that a certain level of violence is seen as a routine feature of nursing home life. So staff in nursing homes, even in the very best nursing homes, are so accustomed to violence that it's seen as a fundamental feature of the setting, and that it's not something that can be eliminated. As I said earlier, the problem is hidden in plain sight. It's something that everyone who's spent more than a day or two in a nursing home has witnessed or experienced, and yet it attracts very limited attention. It's what sociologists call a taken for granted aspect of the social setting in long-term care. I myself, doing research, have been hit by a resident. I was tempted to say, I don't even work here, but it's something that we routinely observe and experience. So because there's such universal acceptance of violence in nursing homes, it's hard to make headway with either policymakers or the general public. And here's one way I've learned this firsthand. In two different studies, both of which I've mentioned to you, staff reports of their own violent behavior towards residents, and the other more recently on violence among residents. We held press conferences to announce the findings. So at like major national meetings, there was a press conference, many reporters. Each time I expected the high prevalence rates of violence and other forms of abuse to cause people's jaws to drop, that there would be a shocked reaction followed by calls for new programs and policies. Instead, my colleagues and I are invariably greeted by a muted response with sad head shaking and resigned expressions, and the reactions can be summed up as follows. Well, of course bad stuff like violence happens in nursing homes. It's what we expect, and what can you do? So I've received the same response when speaking to nursing home operators and to direct care staff. The response to news about how much aggression and violence there are in nursing homes falls into the category of what everybody knows and can't do anything about. So sometimes I speculatively float this idea. Why not a campaign to end violence in nursing homes? So why don't we throw our resources and attention to ending violence? And I'm invariably met by pragmatic skepticism and an overwhelming sense of, well, that's just the way it is. So my argument for you is that we should learn from other national and international violence prevention efforts, treating the high rates of nursing home violence as a serious public health problem with immensely damaging consequences. And over the last few years, I've been doing work with the World Health Organization in Geneva, which sponsors major violence prevention programs. And I've been very influenced by how they do this kind of thing. So rather than accepting the inevitability of nursing home violence, let's be inspired by other social problems that were also taken for granted and for which there's zero tolerance. Now, I promise I'm not going to take anything away from the next speaker, but I do want to say, to make my point, that a really good example is the issue of bullying in schools. So I was in elementary school in the 1960s, in the early 1960s. So I'll reveal my age gladly. And when I was in school, at Prospect School in a small town in Ohio, bullying was a way of life. And the idea that any of us would have ever reported being bullied to school officials would have seemed absurd. Who wanted to be labeled a sissy or a tattletale? And certainly the idea of reporting being bullied at school to one's parents never entered our minds. It was a fact of life, and you figured it out on your own. So if I had surveyed teachers in 1965 or 66 and said, can we eliminate bullying in our schools? They would have thought I had lost my mind. It just was what kids do, and you let them struggle it out themselves. So look at the difference today. Broadway has an annual event against bullying, and teachers can put up no bullying zone signs in their classrooms. People sign a pledge to end bullying. October is National Bullying Prevention Month in schools in the U.S. And the U.S. government, has also got into the act with stopbullying.gov. So here we have an example of a form of violence or abuse that was once routinely accepted and is now subject to zero tolerance. And there are many things like that. Look at, contrast the world of the TV show Mad Men with the Me Too movement. It would have been incomprehensible. So the case of bullying is instructive, and I know my colleague's going to, directly talk about it in long-term care, but I only use it as an example, a brief example of a kind of violence that was once widely accepted, thought you couldn't do anything about it, and then people changed their minds about kids and bullying. And it's instructive because it involves a system-level response. There's the government action, the development of evidence-based programs and public awareness campaigns, and citizen action. But what was needed was the end of acceptance. So when schools begin to declare themselves violence-free zones and foster zero tolerance for violence behavior, why can't we do that in the nursing home? Yes, it's a rhetorical device because you can never eliminate these problems. But I think we need some kind of a campaign, some kind of an effort to shake up the prevailing view of that violent behavior towards residents and staff is normal and acceptable. The second barrier, I'm blaming researchers. So this is not ignorance on your service provider's part. This is that researchers haven't provided much good evidence on the topic of nursing home violence. There isn't very much research, and it's methodologically very weak, so we haven't provided you with a very good evidence base to combat nursing home violence. And there are a couple programs. I'll show you the URLs on the last slide. So things are advancing. And I do know that the next speaker is going to talk, I think, about sort of evidence-based ways to prevent bullying, and that's a huge advance. So if you combine acceptance of the problem with scientific ignorance, you come to inaction. And I would argue again that because violence is built into the daily experience of life in a nursing home, and because we don't have an evidence base available to diagnose and treat it, the easiest thing is to do nothing. And the most obvious symptom of this state of denial is this. We have a situation where nursing home staff are not routinely provided with comprehensive violence prevention training. So that's actually remarkable. There are fully evidence-based violence prevention programs in facilities for troubled youth. And there's no reason why such models shouldn't be adapted and made mandatory for all long-term care staff when they are dealing with violence every day. I'll give you an example. At Cornell, there is probably the leading residential child care violence prevention model in the world. It's required in all youth facilities, and they do what they call therapeutic crisis intervention throughout the U.S. and throughout the world for homes serving troubled youth. And they teach things, as you can see here, crisis communication, behavior support, cycles of conflict, how to manage aggressive behavior. Our staff simply do not know if someone grabs onto your hair and starts to pull it, how do you get them to release you without injuring them? Most places have no protocols for dealing with violence, besides potentially psychopharmaceutical restraint or isolation. So we're putting people in situations where they deal with violence every day and don't teach them how to prevent it and deal with it. So that's a good example of inaction where there are obvious solutions. So what we need to do is to develop new evidence-based interventions. But developing interventions require honestly acknowledging what I would call an epidemic of violence in long-term care. And so we need to bring the problem out in the open, get sound research going, but also get people like you in the field thinking about it and talking about it. So one question we're posing, we aren't arguing it exactly, my colleagues and I, but in addition to talking about overall quality of care and improvement of nursing home culture, et cetera, if we can't eliminate violence and the threat of violence, what are we doing? Shouldn't violence prevention and long-term care be an extremely high priority in and of itself, the same way it is now in schools and in other, venues? So, the way forward. So the question is, what is the way forward? Well, I argued that. I will. See what my next. Hold on. It's not my. Sorry. Oops. So in terms of changing this norm of acceptance and having a campaign focused on violence, I'd like to give you a few ideas here, which come from other fields. And there's a great model in the World Health Organization's World Status Report on Violence Prevention, which you can see. Now, it doesn't deal with nursing home violence, of course, but it gives us some great ideas. I think that we need all stakeholders to come together somehow and engage in activities that are commensurate with the extent and potential harm of the problem of nursing home violence. I think there should be a full-blown public health response to this problem. And first and foremost, but we need to change the norms that allow participants in the nursing home to believe that high rates of violence are inevitable. Renorming campaigns have been used with other negative behaviors. On my campus, you will see public renorming campaigns about things like binge drinking. And, if there's a pretty intractable problem, it's college student binge drinking, right? For any of you who live on or near college campuses, but people are still trying to renorm. And so we need to to change norms that accept violence. Nursing home violence isn't like cancer or Alzheimer's. It's 99% preventable. So a campaign could have a very positive tone. And I would argue, and I'd be interested if we were in a conference, I'd be asking you to dialogue with me even more, but we'd appreciate email feedback. We think that a campaign specifically focused on violence, rather than simply lumping it with other elder mistreatment prevention or efforts to improve the quality of care, could be really useful. And so we take the examples of schools. In schools, violence prevention has been singled out as a specific goal, but because of the extent of the harm. We don't just lump it under quality education, for example. And in the same sense, taking on this issue of violence and trying to reduce or eliminate it, we're hypothesizing might be a good way to go. Another really important thing to do is to strengthen data collection on extent and the causes. We have created some methods of real-time collection of data on resident-to-resident aggression. It's part of our intervention, which I will show you the URL for, in which staff, for a week or two, have what looks like a little prescription pad. And when there's an event of resident-to-resident elder mistreatment, they note it, they write down a few things about the circumstances and put it in a box. That lets people see how extensive it is and how routine it's become. My colleagues need to work with people like you in the field to do really good evaluation studies of ways to treat it. Do other programs available that deal with difficult resident behaviors help? Does behavior modification help? Does different ways of assigning roommates or do design issues help? What kind of staff training helps? We need more studies like that. We need a national plan to end violence in long-term care. And, we need help from the government to find the kind of data we need to inform it. So we need data on prevalence, who's affected, risk and protective factors. Another issue is to enforce existing laws and to review their quality. There are some laws that do exist for dealing with nursing home violence, but often they aren't enforced. And we need to look at the quality of these laws and see if they're helping. And finally, we should set baselines and targets and track progress. This might sound obvious, but if we had some kind of baseline rate of violence in nursing homes, then we'd know if interventions are helping. And I think this is an area that could be really encouraging, because if we know how many violent incidents occur, say in a region or in a community, you can really see the progress you're making by reducing it. So it's a challenging task. It's hard to collect this kind of data, but the payoff in showing that the extra effort is working is worth it. So to close, in sum, what do we think we need, or what's the idea we're floating in venues like this? It's a national action plan to end violence in nursing homes. That we should aim to eliminate nursing home violence as a discrete effort, in addition to other attempts to improve life in nursing homes. Because as I said, if we can't ensure violence-free environments, you have to stop and ask what we really are ensuring if you're dealing with the most vulnerable people in our society. And I think we argue that we should engage providers and policymakers and advocates like you folks in this effort. And nationally, the problem should be treated like other public health crises, and given the importance it deserves. So, as you're going back to work and you want something to think about, it'd be great to give a name to such a campaign, something more creative than ending nursing home violence. But sometimes things get off the ground because, they have a great name. I mean, look at the Me Too movement, so that we need a name of some kind for this. Some people have inquired about what could you do now, or what could you recommend. Unfortunately, there are not, as I say, I think that you're going to hear about an extremely useful program next, so I won't say too much about this. The resident-to-resident violence prevention program that we have developed is available at this website, and I presume you'll get copies of the slides. And that is pretty much of a turnkey program. It comes with videos, with the kind of short-term record keeping that staff are asked to do, and you can find a lot of information on resident-to-resident violence prevention. There also is an excellent program done by a group called CARIE, C-A-R-I-E, and some of you may know about that organization because of the work you do. They have a truly evidence-based program to help prevent violence from staff towards residents. It's called Competence with Compassion, and it really helps staff to understand triggers, from the very specific, like, if someone's agitated, it may not be the best thing to lay a hand on them to comfort them, that you may get yourself in a difficult situation, to thinking about care planning for potentially violent residents, and so forth. So that is directed towards staff. It's essentially an abuse or violence prevention program for staff to help to reduce their chance of acting inappropriately. And finally, and I really will end here, there of course are a number of evidence-based programs which you can find easily on the web for helping residents to reduce aggressive behaviors or difficult behaviors. And I won't go into those. That'll probably be another topic for another webinar if you haven't done it. So in terms of resident to staff aggression, there are good programs available for that, which I haven't listed here. So I think I am done at this point, and Carol, I assume I now concede control of the slides to someone else, but
Yep. Dr. Pilcher.
I've moved it over to the next one.
Yeah, thank you. We'll turn it over to Sarah. I do want to read one comment that came in from a colleague of yours. A good and welcome idea to pursue this campaign. Thanks. Question: how can we address a phenomena such as resident-to-resident incidents that is not even captured in the MDS 3.0 Behavior E section? How can we address this phenomena when there is no F-tag specifically for these resident-to-resident incidents beyond the general state surveyed deficiency citations of abuse and neglect? If you don't capture it, it doesn't exist.
Do I have a minute to respond?
Yes, you do.
That is just an extraordinarily astute comment. It is absolutely right, and we're just starting to think in that direction. There are some of you who I'm sure have more influence with CMS, than we do. I think that is a fantastic idea. I think of things like it, and this may not seem like the best analogy, but it took a long time, but we finally have elder abuse related questions on the licensing exams for geriatricians, for example, but something like that takes ages to do. I think, I think that that's a fantastic idea to at least have it as part of record keeping. It's so difficult in our study of resident-to-resident elder mistreatment. Very few incidents that we uncovered through observation or self-report were ever reported as incident or accident reports, for example. So that question is absolutely right, and I think that would be a huge step in the right direction. I can only agree that that's really a way that we need to progress.
Well, thank you, and thank you for challenging us to look at this issue head on. I'll be interested to see if maybe in the evaluation survey that people will get following this webinar, if you've thought of a name, a possible name for the campaign, you could include that in your evaluation, or
yes.
Later on, you'll be at any point be able to contact Dr. Pillemer, or you can send thoughts to the Ombudsman Resource Center, and we will pass them on. So at this
and Carol, could I add? I think that's a great idea. I'm not sure how quickly we'll progress, but if folks are interested in if we start something, being engaged or involved, if they could mention that on their evaluation forms, that would be great.
Okay, well, great. Well, hopefully there'll be some other thoughts and questions for you following Sarah's presentation. So you can mute yourself. Don't put us on hold. But if you'll mute yourself, we'll get to some questions in about 20 minutes. So Sarah, please talk to us about the training that you and your colleagues have developed in Michigan.
Thank you so much, Carol, and thank you for having me here to the Consumer Voice, and Carol, to you and Katie and Dr. Pillemer. It was wonderful to hear about your research. We actually used a lot of Dr. Pillemer's research in the development of this program, so it really is a pleasure to be here today with you all. So I think I want to start by asking those of you who are with us today some questions that can kind of help us hopefully to better understand what we're dealing with. And these questions were also asked of staff in long-term care and at Commission on Aging's and senior centers and adult foster cares. And we'll talk about that in a minute. So if Katie can pull up our first question, which is, do you believe that senior-to-senior bullying occurs in the organization where you work? So if you're an ombudsman, you're going to want to think about the facilities that you visit. If you work in a long-term care setting, then absolutely. But we're really looking at wherever you provide services to seniors, do you see senior-to-senior bullying happen? And while people are answering that question, I just want to give a little bit of our grant information. Our senior-to-senior bullying reduction for staff training, we call it the CORE campaign, the Campaign of Respect and Empathy, was developed by the Michigan Region 9 Area Agency on Aging as a result of funds from the Prevent Elder and Vulnerable Adult Abuse, Exploitation, Neglect Initiative, which we call PREVENT, made possible by the Michigan Department of Health and Human Services Aging and Adult Services Agency. In 2017, we were extremely proud to receive an N4A Innovation in Aging award accomplishment for the program in long-term care. So have we had enough time to answer the first question?
Yes, we have about 61% that have answered.
Okay. Should we wait a moment or move to the next question?
So, do you see the results on the screen?
I don't. Yeah,
Okay.
you may want to read them, Katie.
Sure. So we have 33% said strongly agree, 43% said agree, 15% said neutral, 5% said disagree, and 4% said strongly disagree.
Great. So, I mean, that tells us right away that we are definitely seeing this senior-to-senior bullying happen, without a doubt. So I'd like to go to the next question, which is, please check the box for any of the senior-to-senior bullying that you've witnessed in the past 30 days. So there's physical bullying, social bullying, verbal bullying, or sexual bullying. If you've seen all of them, please check all of the boxes. And as people are answering that question, I will tell you a little bit more about what we've studied and what we've developed.
Sarah?
In 2006, yes?
This is Carol. I'm sorry. I may not have set this up correctly, and people may only get to vote for one. So
That's okay. If people are only able to vote for one, I'd like them to vote for the one that they have seen the most prevalently in the past 30 days. Thank you. So in 2016, we initially received this grant, and it was decided we wanted to tackle senior-to-senior bullying. So we focused on the skilled long-term care facilities, skilled nursing facilities within the Region 9 area. In Michigan, we're the northeast corner of the Lower Peninsula. We cover 12 counties, so we had 21 different nursing homes participated. We only sent initial surveys to staff members before they ever took the training. We had about half of those facilities participate in the actual training. All but one of the facilities turned in staff survey responses. In 2017, which was last year, we were again awarded the grant, and we focused on Commission on Aging or Council on Aging and senior centers within our region. Again, we have 12 counties. We had 11 that participated in the actual training, and we were able to give pre and post surveys to both staff and the consumers in those settings to help us get some better information about what was happening out there. We also were able to provide the training and the surveys and the whole shebang to licensed homes for the aged and adult foster care homes. However, our feedback was extremely minimal with the homes for the aged and adult foster care homes. At that time, we had about 125 different licensed homes of those types within our region. We had 4 homes actually participate in training with a total of 7 individuals out of all those 125 homes. So I think that's a whole different webinar to talk about that issue with. So we will focus on the information that we got from skilled nursing facilities and the Council on Aging and senior centers. And this year we're able to provide this training statewide, focusing on the Area Agency on Aging staff and our long-term care ombudsman to make sure that there are trainers throughout the state to be able to offer this in any place where individuals serve seniors. Excuse me. So everybody's had time to answer that question. How did the results come out, Katie?
9% said physical bullying, 29% said social bullying, 60% said verbal, and 2% said sexual.
Okay. And I'm not saying that's great. I'm saying it's great that these responses kind of match up what we've found here in Northern Michigan. So the first year, like I said, we surveyed long-term care staff before they received this training. Excuse me. And we asked them, does bullying occur in the facility where you work? And as you can see, 55% of people said yes, they agreed or strongly agreed that senior-to-senior bullying was happening. 17% had witnessed physical bullying in the last 30 days, 35% social bullying, 44% had personally witnessed verbal senior to senior bullying, and 6% of staff surveyed in those 21 nursing homes had seen sexual bullying. We also asked the question, do you feel that senior to senior bullying is a major problem at the organization where you work? These are the results of that. We had 9% of long-term care staff, that's where the red line is on these graphs, 9% felt that it was a major problem, even though in the past 30 days, they were ready to say, absolutely, we've witnessed this happening. Yes, we agree that bullying occurs. Only 9% really recognized that it was an issue that needed to be dealt with. We did get some responses, a little over 100 total staff responses individually for our pre-surveys and our post-surveys. So we asked the same questions and the results were basically the same. Yes, 22% said the senior to senior bullying happens, but only 5% felt that it was a problem. We had people witnessing physical bullying, witnessing social bullying and sexual bullying and verbal bullying and any type of bullying, but only 5% of those staff members in homes for the aged and adult foster care felt that it was a major problem. These are some of the comments that we've gotten over the past 2 years by providing these surveys, and I definitely felt that the comments gave us a lot of insight into the staff and the residents or the participants of those organizations. And these comments that we decided to include within our presentation kind of summarize most of the comments that we got. The senior community doesn't like people who are living with disabilities. That was from a staff member. And to us, that really shows an inherent bias about what we feel that the senior community can tolerate or is tolerant of. We included the participant statement, I wouldn't step in to help anybody. It's none of my business. That individual had also checked on their survey that they had been bullied and that they'd witnessed every form of bullying within the past 30 days. Better learn to have a thicker skin. We got a lot of those types of comments, both from staff members and participants and residents. And then the last comment was from a long-term care staff survey. And this was a huge part of what we centered the training around. The idea that bullies don't change and that trying to make a change can actually make this person worse. That somehow these people cannot see beyond themselves. They're selfish, spoiled, self-centered people who never learn to share or be polite or care. So did we do the last question yet, Katie?
No, we haven't done it yet. I'll launch it now.
I'd like to ask our participants, how many of you have actually received training on senior to senior bullying? And I made this as an agreement statement, you know, you strongly agree or strongly disagree, because sometimes people relate some of the training that they've received about resident to resident aggression with bullying so that you can decide if you've had that training or not. Onto the Commission on Aging, these are from staff members and these are the before and after. So I wanted to show you the difference that our training program made. Again, we provided it only to staff members. So we did see some significant changes in some areas, especially the areas we wanted. We had more people understanding that yes, bullying occurs. And we had more staff members seeing bullying because maybe, we're hoping, now their eyes were open to this problem. We had more staff members, a higher percentage, understanding that it is a major problem, that they do need to intervene. And this was probably my proudest moment. Well, in the beginning, only around 25% of respondents said that they felt confident in how to intervene. After the training, almost 73% said that they felt confident in how to intervene. We asked if people agreed with the statement that senior to senior bullying can cause avoidance in activities and meals. We had an increased understanding for staff that indeed bullying has these negative effects. We encourage the initiation of a welcoming committee at each organization, which I'll briefly talk about. More people said, yes, we have a welcoming committee, and many more people, as you can see, understood that their organization has policies and procedures of how to respond. Before the training, only 29% of respondents knew that their organizations had these policies already in place. We also were able to see that after the training, staff were less likely to say that bullies will always bully, and we actually had more staff members saying that they were bullied as an adult, which I found really interesting. Excuse me. So I want to talk some about what our training was about. We really tried to let people know what bullying is and how that is distinguished or differentiated from other interactions that we see among any people. So we focus on the idea of power, that the power imbalance is happening, and that one of the individuals, the target, is perceiving this in a negative way. Whether they remember the exact event or not doesn't really matter. They have a negative effect as a result of this interaction that contains a power imbalance. It's not about someone being rude or mean, and we talk about the differences between a rude interaction or a mean interaction and a bullying interaction, which has that power imbalance. We differentiate between a conflict and bullying because we want people to understand that when there's a conflict, there's some right and some wrong on both sides. So we can meet in the middle somehow or hopefully facilitate that. But if we have a situation of bullying, we don't want to put a person that has lesser power at a table for conflict resolution with someone who already has some kind of power over them. I hope that makes sense. And it's also not teasing. We talk about the fact that teasing, although it can certainly escalate into bullying, teasing can also be a really happy, jovial way to connect with friends and family, and that's how some people communicate. And we also talk a lot about basic and safety needs using Maslow's hierarchy of needs, especially in dementia care, because of course, if we're working with the senior population, that's something that we need to understand. We talk about the whole life cycle of bullying, and I hope that you can go home and Google this because there's a whole bullying project that was made, and although it's used for kids, as Dr. Pillamar said, it's used for school-aged kids. There's a lot of programs about bullying that can easily be adapted to any age group. And what we want people who take this training to know is it's not just the target or the victim of bullying or the bully themselves, but every single person in the environment is involved in that interaction, whether they are passive, whether they are actively engaged. It makes a difference. And as Dr. Pillamar pointed out, even just witnessing these acts can have a negative effect on staff and residents or participants. We teach assertive communication, and that's not just so that staff can model that and kind of set the example, but so each senior has a way of communicating as a defense. We use a lot of I statements. We try to teach individuals how to use that and how to teach it to the seniors that they're working with, because an individual who is assertive is expressing themselves without trampling the rights of anyone else. And we try to teach staff members that those are the words they can use, that, you know, we're not going to allow anyone else's rights to be hurt in this environment. We help the staff understand that they can help each person that they serve find their own personal strengths. We even talk about things like medical equipment or assistive devices to help people where they feel powerless. Recognizing and intervening on bullying immediately and consistently. Staff have to know that it's important that every single staff member is a part of this. And creating those welcoming environments. We talked about a welcoming committee, making sure everyone knows that no matter what, this is their community too. Respecting and celebrating differences in cultures. We talk about different ways to do that, whether it's introducing people in interesting ways or having activities departments or different social gatherings happening, and providing that ongoing education to staff and participants. It can't just end with a single training. Everybody, of course, wanted a 1-hour training that would solve all their problems, and that's never going to happen. It has to be ongoing, it has to be consistent, and everybody has to know those standards. So that is our core bullying program in a nutshell.
Great. So, Katie, can you show the results of the last poll?
Sure. So 8% said strongly agree, 18% said agree, 11 said neutral, 37% said disagree, and 25% said strongly disagree.
And it always surprises me how many people have not had training on a type of interaction that, as the doctor said, we have experienced since childhood and never really learned how to deal with appropriately.
Yeah, because this is showing that 50% have not had any training on senior to senior bullying. So, well, Sarah, just like Dr. Pillemer, you have presented some incredible information, and I'm just gonna remind you once again, if you have a question or comment, please type those into the comment box. And Katie, if you'll give me control. Great. And if you'll let me know that my screen is showing.
Yeah, we can see it.
Poop. And guess what I did? I went to, I was so happy that everybody was ready and prepared, and then here I come from current slide. So some of the resources that the National Ombudsman Resource Center has, excuse me, is we have a brand new revised resident-to-resident mistreatment ombudsman advocacy referral guide. We will be sending this out with the other links to this webinar, and we will also be including it in the Outlook that comes out quarterly, and it's actually already on the NORC website. This talks about an overview of resident-to-resident aggression. There are risk factors that are identified with some suggested things that could be done to overcome those risk factors. There are examples of advocacy strategies for ombudsmen to use when they're investigating complaints and helping to work on solutions. And when you get this PowerPoint, if you download it or open it up once the link is sent to you, this is the link to that document, and it's posted on the Ombudsman website under Abuse on the issue page. So one of the things that will be coming out to Ombudsman probably by the end of the week, and all of you will receive a copy of these, but NORC has just put together an in-service training that ombudsmen can talk with nursing home administrators or assisted living facility administrators and offer to do an in-service training on the topic of preventing and responding to resident mistreatment. This is designed as a 30-minute training, or could be longer if that's possible for staff as an in-service. But it has a brief training guide that there's a copy of, and then there's a PowerPoint slide that can be used. And the whole intent here is to maybe in many instances bring this training to the forefront and to encourage nursing facilities and other assisted living homes to begin this conversation, making sure that there are policies and procedures and ongoing training for staff. And of course, we're encouraging the use of individualized, person-centered care and in both the care planning and in the actual care that's provided. So this PowerPoint and the training guide will be available probably by the end of the week. There is also the Consumer Voice has a consumer fact sheet which can be downloaded and given to families at a family council meeting or to residents at a resident council meeting. This is, again, has the overview of resident rights, defines resident-to-resident mistreatment, and explains how to seek help. And those are the URLs right there to get this, to get the brochure or the large font size. Here are some other resources on the issue of resident-to-resident mistreatment. On the issue page, you'll find the first webinar that Dr. Pillemer did for us, as well as other examples of work that ombudsman programs have put together regarding this issue of resident-to-resident mistreatment. There is available for purchase some resident-to-resident elder mistreatment training from the Hebrew Home, and on the NCBI National Health, there is a staff intervention targeting resident-to-resident elder mistreatment that you can download and look at. Those are all three really good places to go to learn more about this topic. And at this point, we're going to check and see, if we have questions from any of you. Katie, I just closed my question box. Is there any questions or comments that we can look at?
Yes, there are a few in here. So one says, what can be done when there is a resident-to-resident assault and the victim wants to file a police report, but the police refuse to take the report? The perpetrator remains in the building and says, they can't make me leave the facility, and nothing is going to be done. Do you have any thoughts? This is a licensed care facility and both residents have no cognitive deficits.
Well, I don't hear any of the other two speakers jumping in.
Well, no, are we unmuted? I wasn't sure if we can.
Yep, you are.
Oh, great. Yeah, no, I mean, I think that other folks are more expert than I am on it. I'll say that in our experience, we have not generally encountered that, so that we found that police engagement has been reasonably reliable in the communities that we have typically worked with. And I think, the thing that we encounter is that they have no training in a situation like this. They're often unsure as to what to do about it. And so we've had them come. I think, that we see they actually come, but then they don't understand how to work with perhaps two demanded people who may not even be able to give an account of what actually occurred. So it would seem to me that maybe police training is what is actually, needed. I guess I have to say it wouldn't surprise me that law enforcement might come and be somewhat, confused as to what their role is. And it would seem to me to be a really high priority to help establish that and figure it out, because I think you're right. I think, they lack guidance on this the way others do. So I guess I would just highlight that as a very important issue, but I'd be very interested to know if that's a problem that comes up frequently.
Yeah, this is Carol, and I would say that it wouldn't be a bad idea to contact the state ombudsman in your state and ask if they have a relationship with law enforcement. We're seeing more and more law enforcement agencies reaching out to the Ombudsman program. Well, communication is kind of going both ways in looking at ways to provide training about nursing homes and assisted living to help them understand who the population is and what, and making sure that they're getting training from dementia, from the Alzheimer's Association or other experts on the disease of dementia and their the ability to not communicate the way that we're hoping that they might. So I would encourage, if you have a question about this, to check with the state ombudsman and see if this is a project that's happening. And if it's not, then maybe it wouldn't be a bad idea to encourage your state associations of either Leading Age or the American or the Healthcare Association of your state, or your Director of Nursing Association or social worker organizations, to all get together and have a conversation and figure out what kind of training might be provided. Katie, what's another question?
Another one is that bullying can be a result from frustration experienced by the resident. How can this be reduced? Also, does staff-to-resident bullying impact resident-to-resident bullying?
This is Sarah. I think that we definitely talk about the fact that everybody who is in a nursing home has suffered losses, and that this creates a unique situation for people who possibly hadn't even considered themselves bullies before or necessarily engaged in that behavior. So part of our training does talk about the specific traits of someone who might be engaging in bullying and someone who may be a target. And we include the ideas that although these lifetime patterns might be there, the significant change and stress that they're experienced by just being in the nursing home, whether it's short-term or long-term, is significant and has to be recognized. So when a person is bullying and they're trying to extract that power from someone else, it shows that they feel a loss of power and control as well. So certainly we always want to work with those residents too and say, how can we help you feel more control in and of yourself, and to develop that personal internal locus of control. And I absolutely agree. Part of the issues with communication is that a lot of individuals, especially those who, we work in long-term care and all of these things, and we're around people all the time, we've never actually been taught how to communicate. And when assertive communication is taught and used all of the time, it sets that standard of communication. So whoever asked that is exactly right. If they're seeing staff bullying each other, because that always gets brought up when I do these trainings, the fact that staff bully each other or residents are bullying staff, that becomes a culture of your environment. I feel the same as violence, as Dr. Pillamar had mentioned, that just becomes normal and no one feels like they need to do anything about it, and it becomes an example. So we want to change that example.
Perfect.
Does that make sense?
Yes, thank you.
Yeah, that, I can't add much to that, except if we had more time, the one thing it seems true here too is that bullying's not just an individual phenomenon, it's groups against groups, and I think that must be challenging to intervene in. We're doing studies in assisted living, and we see that a lot there. I know folks are reading about the sort of mean girls phenomenon in assisted living, and we're finding it is a problem, but it's a group dynamic thing too, and not just individuals, which makes it even harder to deal with sometimes. Agreed.
Absolutely. Thank you. One comment that came in, and Dr. Pillamar, you might help me with his name, but is it Elion Caspi?
Yes, I think that's close enough.
Okay, he's been lurking in the background here, and he just came out with a recent study that's talking about the death of 105 elders as a result of resident-to-resident incidents in dementia, and it's in the Journal of Elder Abuse and Neglect. And if he sent me the link, and if we can get access to that, I'm assuming it's okay for us to send that out also. When this one came out, and I was reading this about the 105 people dying as a result of resident-to-resident incidents, I sent that to Dr. Pillemer and said, "Oh my gosh, look at this study!" And of course, he knew all about it. But so I appreciate your giving us that reference, and we'll make sure that we send out a link to that. Sarah, someone has asked if you would be available to do a train the trainer in another state.
Well, I would suggest that you talk to our Region 9 Area Agency on Aging director. Her name is Lori Sauer, and her title and our phone number is on the slides, I believe on the first or second slide from my portion of the presentation. Or you can certainly shoot me an email. My email address is on there as well.
Perfect.
Does that help?
That's
okay.
Great. Thank you. So the value of the VAPIT system to address abuse is not addressed by police. VAPIT is a federal system with the District Attorney General Office. Does that mean anything to you, Carl?
No, it doesn't. It's like if it's a true-false statement, I'm willing to agree with it, but no, I don't know anything about that system or what it might be.
Okay. Well, I guess that's if there's a system out there to address abuse that's not being addressed by the police, this might be another topic that needs to be added to the conversation. If people,
yeah, you know, Carol, I would that gives me a quick opportunity to say that one other resource might be for those of you in communities where there is a multidisciplinary elder abuse team. So in a lot of cities now, there are MDTs. Bringing a complicated case that involves the police or has involved the police to a local MDT, a multidisciplinary team for case discussion, because they always involve law enforcement, might be a useful tool if such is available where people are.
Okay, great, thank you. One comment, please include in this discussion the increasing incidence of visitor to resident, visitor to staff, resident to visitor, and staff to visitor violence.
I can only say amen. I think that is really, and between family members and staff, yeah, I presume that's what they mean. There's never been a study of this, and that's why I didn't mention it, but my colleague, Dr. Mark Lax, who works in nursing homes frequently, has pointed to a surprising number of family, staff, or staff other visitor, certainly verbal aggression, but even physical aggression. That it would be a great topic for future study and is very difficult for staff. I wish we had more information on it. I could only say absolutely, that's something people should be looking at.
Sure. So one comment, chronic understaffing breeds competition between residents. Animosity increases between residents when one or more resident is perceived as monopolizing caregiver time and attention. That sounds very reasonable.
That might be one for Sarah.
I was just going to say, I agree. And we talk about different types of targets and how people are targeted. And an individual who utilizes or overutilizes the staff time or has a lot of needs can be seen as a provocative target, a person who, without better words, people would say has it coming, or they earned the bullying. And so that's part of working on the change in perception and educating people about disease processes and helping people to find that internal locus of control. And I absolutely agree. Those individuals, those provocative targets, even when they have behavior they can't control, such as an individual with a dementia-related illness who might cry out in the night often or during meals. That's a difficult thing to deal with because we may not be able to change their behavior, and thus we're always going to be dealing with the reactions of others to that behavior.
And could I add to that, we found in our studies, again, one of my colleagues has referred to them as the frequent flyers of resident-to-resident elder mistreatment. The profile that we found, the most typical person to be involved in these cases, and especially the perpetrator of them, are individuals who are ambulatory, in relatively better health, and with moderate cognitive impairments. And so they're able to get around. They are able to either place themselves in harm's way or to disturb other residents. And very frequently there'll be a lot of events that are actually related to a single person. So I think that fits into that same model, and it also is a pathway for intervention. It may be that to reduce resident-to-resident elder mistreatment, you may only have to intervene and care plan and work with a relatively small number of people, because there are clearly people who are more likely to be provoking incidents and be engaged in them. So I think that's a really good point.
Agreed.
Okay, and the VAPIT is a new law that allows public to gain access to elder abuse information. So there's also something called the CRAE in Memphis, Tennessee, Coordinated Response to Elder Abuse. So people are sending in some good information here. Katie, are you seeing other ones that?
Yes. So ones that were sent in earlier. Let me just get to the top. Have you seen any unintended consequences of increased discharges based on the bullying resident being harmful to others?
Well, this is Sarah. I haven't actually, and I'm an ombudsman, so I haven't personally been involved in any situations where an individual has been discharged because they were engaging in bullying or because they were a target of bullying, frankly. But I'm sure that does definitely happen. Yeah, I'm not really sure how to answer that any more than that. I haven't personally been involved in any case where someone has been discharged because of that type of behavior.
And I would say this comes up very, very frequently in discussions with nursing home staff and with administrators. They do see this as a solution, and especially if someone is very violent. For example, nursing homes that begin to worry greatly about liability, and they really want to move people into psychiatric care, so that it's not so much that they are able to do it, but we have encountered a frequent desire to do it, to get somebody out of the nursing home and into psychiatric care. And one reason, if you see lawsuits in nursing homes, that's a frequent complaint, is why didn't you just get that person out of there who was so dangerous? So they're walking a very fine line. We've definitely seen it in the community, in the facilities that we work with, of either temporary or some other kind of even permanent relocation for psychiatric reasons does happen. I'd agree with Sarah, though. It's not that they wouldn't want to do it, but it's very difficult to do it, I think. So I don't think it's that common that it actually occurs, personally.
I agree. And I definitely do see clients, residents who are sent out to psychiatric units for various reasons. So you're right. Thank you for that clarification.
But permanently discharging them, I'd agree, it's almost impossible, I think, at least not for this particular reason.
Agreed.
Okay. I want to mention that the Consumer Voice will be having a conference coming up in October, and one of the presentations there will be on resident-to-resident aggression, bullying, so if you are thinking about going to that conference, you might look for that particular session. Katie, is there any last question?
I don't see any.
Okay. Well, I did see one suggestion for a campaign title, so I'm going to encourage everyone to continue to think about that. But fighting for dignity.
I love that. That's great.
Yeah, that's kind of putting your face right into the fact that we're talking about nonviolence, and yet we're going to fight for something. But hey,
yeah,
we'll put that in the hat. So I want to thank all of you for joining today. I want to thank Dr. Pillemer and Sarah for presenting, and Katie for being our technical person. You will be receiving a short survey, evaluation survey. We would love to have you fill that out, give us feedback on how we can improve these webinar trainings, and we will be sending a copy of this webinar and the handouts to you probably tomorrow. So please feel free to share those. Hope you have a good day, and thank you.
And Carol, is there? Could I make one last quick comment?
Yes.
I just want to say thanks. It's so honored to be able to do this with you, and just, having worked with ombudsman programs over the years, have extraordinary admiration for everything you folks do, and a lot of gratitude to folks in your field who have helped us to do a research project. So I just do want to commend everybody on the line for the unbelievably valuable work you're doing, and thank you for letting us be here with you, because it's quite a privilege.
Well, you are welcome, and on behalf of all of the ombudsmen across the country, we thank you for those kind words. So,
yes.
Sarah, do you have a last thing you'd like to say, as long as we're blubbering?
No, it's an honor to be here today. I hope that this information was valuable to some of you, and feel free to contact me if you have questions.
Great. Thank you very much. Everybody have a great day.
Thank you.